Hi everyone, welcome back. In this video, we're going to learn about an important cause of anemia, which is thalassemia. Let's start with an interesting fact. The name thalassemia actually comes from an ancient Greek word called thalassa, which means the sea, and it actually referred to the Mediterranean Sea. And it's actually because certain types of thalassemia have a higher prevalence in people that are from the Mediterranean. So now, if you're ready to learn more about thalassemia, let's get started. Thalassemia causes microcytic anemia. Microcytic means that the cells are small or micro. This is defined as anemia where the MCV, which is the average size of a person's red blood cells, is less than 80 femtoliters. The normal range of MCV is 80 to 100 femtoliters. So this one is microcytic because the red blood cells are smaller than normal. There are 5 main causes of this microcytic anemia, which you can remember by the mnemonic TAILS, which stands for thalassemia, anemia of chronic disease, iron deficiency anemia, lead toxicity, and sideroblastic anemia. And one caveat is that anemia of chronic disease and iron deficiency anemia can cause not only microcytic anemia, but they can also cause normocytic anemia, where the MCV is normal and between 80 to 100 femtoliters. Now, what's most important to know is that the underlying mechanism for all of these microcytic anemias, regardless of which one is the cause, is always going to be decreased hemoglobin synthesis. So regardless of what is causing the condition that's leading to microcytic anemia, the reason for the anemia is going to be a decrease in the synthesis of hemoglobin. And in this video, we're going to focus on thalassemia. So now let's learn a little bit about that hemoglobin. It's the main content inside of mature red blood cells, and that's because it's the part that binds oxygen and helps deliver it to tissues, which is the function of these red blood cells. And as you can tell from the name, it's made up of 2 parts, heme and globin. Globin is the protein component of this hemoglobin molecule, and it's made up of 4 polypeptide chains or subunits, 2 alpha and 2 beta in adults. Within each of these globin subunits, we have the heme part, which itself is composed of iron bound to proporphyrin. Now in thalassemia, the problem is a decrease in the globin proteins. So there's nothing wrong with the heme portion. The defect is in the production of either alpha globin, which causes alpha thalassemia, or beta globin, which causes beta thalassemia. Okay, so since thalassemia is a problem with globin, let's start with a quick mini lecture about globin and its different types. I said on the last slide that most hemoglobin is composed of 2 alpha and 2 beta chains, and this is true, but those aren't the only globin types. There are actually 4 main types of globin that compose hemoglobin. There's alpha and beta, which we already mentioned, but there's also gamma and delta. Alpha is encoded on chromosome 16. Beta, gamma, and delta are encoded on chromosome 11, and then normal hemoglobin is always going to have 2 chains that are coming from chromosome 16, so this is always going to be alpha right here, and then 2 chains that are going to come from chromosome 11, so it's going to be either beta, gamma, or delta that are going to pair up with it, and depending on which of these 3 it takes, that will determine the type of hemoglobin. So if alpha 2 pairs up with gammas, then we have hemoglobin F, or fetal hemoglobin. If alpha 2 pairs up with 2 betas, then we have hemoglobin A, also known as hemoglobin A1. And this is what I mentioned as the most common hemoglobin in adults, composed of 2 alpha chains and 2 beta chains. And then finally, if we have alphas combined with 2 deltas, then we have hemoglobin A2. Now, if we were to do a hemoglobin electrophoresis, here's what we would see in normal conditions. So before birth, we're going to have more gamma globin and less beta globin. So in the fetal period, the main hemoglobin type is going to be hemoglobin F with very little hemoglobin A. And this is physiologically important for the fetus's ability to extract oxygen because hemoglobin F has very high oxygen affinity compared to the other types. After birth, these ratios are going to switch. So we're going to get a gradual drop in gamma and a rise in beta synthesis. So in the first few months of life, there's still a fair bit amount of gamma around as beta is ramping up. So we're starting to make hemoglobin A, but we still have a lot of hemoglobin F around in the first few months of life. And typically it's after 6 months of age that the levels of hemoglobin A start to exceed the levels of fetal hemoglobin. And then finally, we have our 3rd stage right here, which is considered the adult stage. Really, it's just anything beyond 6 months of age or so. And here, the main hemoglobin by far is going to be hemoglobin A, with only a small amount of hemoglobin A2 and negligible amounts of fetal hemoglobin. And now, as we're going to start learning about thalassemia, you'll see how the globin chain mutations are going to alter these results in the different types of thalassemia. All right, so let's talk about thalassemia. This is the T in our tails mnemonic. The problem with thalassemia is an inherited mutation. It's autosomal recessive, and the gene is either the alpha or the beta globin chain gene. So what's going to happen is that we're going to have decreased production of the globin chain, either alpha or beta. This is going to lead to decreased hemoglobin, which, as you know, is going to cause microcytic anemia. One thing that students often mix up is the difference between thalassemia and sickle cell anemia. In thalassemia, we have a decrease in the production of the globin chain. So we have decreased hemoglobin. This is a quantity problem, so it's going to cause microcytic anemia. Whereas in sickle cell anemia, we don't have a decrease in the amount. We have production of abnormally shaped hemoglobin. And so this is a quality problem, and this is going to cause normocytic anemia. And I'll explain and go through sickle cell anemia in the separate videos under normocytic anemia. But for now, let's focus on thalassemia and talk about the difference between alpha versus beta thalassemia. Okay, so let's start with alpha thalassemia. The problem here is with the alpha globin chain. That's why this is known as alpha thalassemia. And the alleles for the alpha globin chain are on chromosome 16, and there's actually 4 alleles. So there's 2 on each copies of chromosome 16 for a total of 4. So a normal genotype would be alpha, 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 as shown here in this picture. So now let's talk about the symptoms associated with alpha thalassemia, and let's go through it because it depends on how many of these 4 alleles are deleted. So the top row right here is alpha, 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 alpha. So this is basically normal. There's no thalassemia going on here, so obviously no symptoms. If there's one of the alleles that are deleted, then we have what's called a silent carrier because this person still has plenty of genes to produce enough alpha globin chains, so no symptoms. If 2 are missing, both alleles could be missing from the same chromosome or one allele from each copy of the chromosome. Either way, this is called alpha thalassemia trait, and that's because these patients are either asymptomatic or only have mild anemia. That's because they essentially still have 50% functional capacity of their alpha globin chain, so they'll be fine. The ones that are going to be the problem are these last 2 right here. So if 3 out of the 4 alleles are deleted, this is very, very severe anemia. This is called hemoglobin H disease. Hemoglobin H is when you have beta globin tetramers, and these guys form because there's very little alpha around, so the beta globins are going to form tetramers. The problem is that when the beta globin form tetramers, they're actually going to precipitate inside those red blood cells and cause hemolysis and make the anemia even worse. So these patients are going to have severe anemia and are going to require very frequent red blood cell transfusions to help treat their symptoms. And the final form is the most severe. It's when all 4 alleles are deleted, and this is essentially incompatible with life and usually causes fetal death even prior to birth. What happens here is that since there's no alpha globin at all during the fetal period, the remaining chains, which in this case are going to be the gamma globin chains, are going to form tetramers. So we're going to get these gamma globin tetramers, which is known as hemoglobin BARTs. And this hemoglobin is not functional and it can't carry oxygen well. So this is going to lead to a massively profound anemia and a secondary high output cardiac failure, and this condition is called fetal hydrops or hydrops fetalis, and unfortunately this is usually not compatible with life and leads to death in utero. Okay, so let's move on to beta thalassemia. The problem here is with the beta globin chain, and remember the gene is on chromosome 11, and unlike alpha, there are only 2 alleles here for beta, so 1 on each copy of chromosome 11, so our normal genotype is going to be beta/beta. The other important thing that's different than alpha thalassemia is that the symptoms of beta thalassemia are not going to show up in the fetus. And in fact, they probably won't show up until after 6 months of age. And that's because up until then, we primarily use what's called fetal hemoglobin, which is made up of alpha and gamma. So a beta deficiency is not going to affect that. So this is a very high yield and important fact to know about the difference between beta and alpha thalassemia, that for beta, it doesn't show up until after 6 months of age or so. So now let's move on to the types. And first, here is the key to the alleles, because this is important to know to interpret this. So when you see just the letter beta by itself, that means this is a normal allele. When you see it with a little plus sign, that means that the mutation is causing a decrease in the function of that allele, so it's going to cause less beta globin to be made from that gene. And then when you see it with a little 0 next to it, that means that the mutation is causing a complete loss of function of that allele, so that nothing is going to be made, no beta globin is going to be made from that gene right there. Okay, so now let's look at the symptoms right here, and there are 3 disease categories. The first one is thalassemia minor, and the genotype here is going to be beta with either a beta plus or a beta 0. So either way, there's at least 1 normally functioning allele, so a decent amount of beta globin chain is still going to be made. And so this patient is going to have either no symptoms or only mild anemia. And on their hemoglobin electrophoresis, we're going to see a mild decrease in the normal hemoglobin, which is hemoglobin A, and a mild increase in hemoglobin A2 to make up for a little bit of that loss of the beta globin chains. The next one is the medium severity. So this is thalassemia intermedia. And here, both copies of the gene are going to have some abnormality. So the genotype is going to be beta plus with either another beta plus or with a beta 0. So either way, there's at least one beta plus, which means that some beta globin is going to be made. So we don't have a complete absence of beta globin, but it's still a pretty significant loss of it. So these patients are going to have pretty significant symptoms and at least moderate to severe anemia. And then the final category here is going to be the most severe or the most major. That's why it's called thalassemia major. And so here, both copies of the gene are beta 0, so they make no beta globin. So this patient is going to have severe anemia and is going to need very frequent red blood cell transfusions. And on hemoglobin electrophoresis here, we're going to have no hemoglobin A because we have no beta globin. And instead, we're going to have high levels of hemoglobin A2 and fetal hemoglobin because the alpha globin chains are going to link up with the delta and gamma chains instead. Okay, so now let's talk about the clinical features that are high yield associated with thalassemia, and there are 4 major categories of complications here to keep in mind. So number 1, we have decreased globin chain, either alpha or beta, which is going to cause underproduction of hemoglobin, which is going to lead to microcytic anemia. This is going to be the key tip-off. Number 2, because of the abnormal globin chain tetramers that can form, these can cause hemolysis of the red blood cells as they filter through the spleen, and this is going to cause 3 separate issues. Number 1, this destruction of the red blood cells is going to further exacerbate the anemia. Number 2, the spleen is also going to get congested by all the breaking down of the red blood cells, which is going to cause it to enlarge in size, and this is called splenomegaly. And then finally, there's going to be a large rise in the bilirubin because it's a byproduct of heme breakdown, and the high bilirubin levels are going to cause jaundice as well as can lead to formation of pigmented gallstones. Now, number 3, we're going to have something known as erythroid hyperplasia to compensate for the severe anemia. Erythroid refers to the red blood cell precursors, and this means that they're going to proliferate or undergo hyperplasia to make new red blood cells in response to our severe anemia. And these red blood cell progenitor cells are mostly in the bone marrow. So classically, hyperplasia is going to cause these patients to have thickening of some of their bony structures. Most apparent is going to be prominent skull and facial bones. The red blood cell progenitor cells are also going to be found outside of the bone marrow, and they can rev up production there as well. So this is called extramedullary, meaning outside the bone marrow, hematopoiesis, and the 2 main locations for this are the liver and the spleen. So this is going to cause enlargement of these 2 organs, which is known as hepatosplenomegaly. So now we have 2 reasons for the spleen to be enlarged and undergo splenomegaly. And then the final complication is actually iatrogenic, meaning it's caused by the medical treatment of thalassemia. So most patients with severe thalassemia are going to require frequent red blood cell transfusions. And since these red blood cells are also containing iron, these patients are going to end up developing iron overload secondary to the blood transfusions. And this is known as secondary hemochromatosis. And this is a problem because this excess iron can deposit in the different organs like the liver, heart, skin, and pancreas and become toxic. Okay, so now let's talk about how to diagnose thalassemia. There are some clues here that can help. So first, this is an inherited autosomal recessive condition, so family history might be positive for thalassemia in that autosomal recessive pattern. Second is ancestry. So thalassemia is more prevalent in areas where malaria is endemic. It's thought that that's because the thalassemia mutation can actually protect against malaria, and this is going to lead to an evolutionary pressure for that mutation to have survived in those regions. So generally speaking, alpha thalassemia is more common in people of Asian and African descent, whereas beta thalassemia is more common in those of Mediterranean descent. Now, I want you to be careful of just trying to use this as the only way to make the diagnosis. Just because someone has an ancestry from one of these regions and they have anemia doesn't mean that this is caused by thalassemia. And also, on the other hand, just because someone doesn't have this ancestry doesn't rule out thalassemia. And test makers actually know that students have memorized this association, so sometimes they may try to trick you by giving you an ancestry in a test question that is not relevant. So the bottom line with this ancestry is that you should know this association, but don't use it as the only basis to rule out or in thalassemia. Another clue is the RDW, which is the red blood cell distribution width. Basically, it's a measure of the variation in the size of the red blood cells in a person. So in iron deficiency anemia, which is another major cause of microcytic anemia, this RDW is going to be elevated, and that's because the cells are going to start off first as normocytic at baseline, and then gradually they're going to get smaller as there's less and less iron, so there's going to be a wider range or variation in their size. In thalassemia, on the other hand, the RDW should generally be around the normal range, and it should be less than iron deficiency anemia, so it shouldn't be elevated. That's because thalassemia is an inherited genetic condition. So all the red blood cells in that person are pre-programmed to start off with the same mutation that causes them to be small, so there should not be a wide range or variation among their sizes. And then the final clue is going to be in the peripheral blood smear. You might find something called target cells. And here's an example of one on a smear right here. It's basically just a dark central spot that makes this look different than normal red blood cells and makes it look like a target. This is not specific to thalassemia and can occur with many other diseases, although on many test questions, it's used in association with thalassemia. So you should just keep it in mind. Now, to actually confirm the diagnosis of thalassemia, we have two good tests. The first one is hemoglobin electrophoresis. So you can check out the patient's hemoglobin, and you would expect to see low levels of the normal hemoglobin A and elevated levels of the other types. And then you can also do DNA analysis in some cases to confirm the diagnosis and identify the specific genetic mutation. So let's wrap up by learning about the treatment of thalassemia. There's no cure for thalassemia yet, so treatment is focused on managing the symptoms. The main treatment for these patients is red blood cell transfusions to treat the anemia. And of course, the more severe the disease, the more frequent these transfusions are going to be needed. Now, as we talked about a few minutes ago, a consequence of these frequent red blood cell transfusions is iron overload and secondary hemochromatosis. So some patients may need therapy with iron chelators to remove the excess iron. And then finally, in some cases where hemolysis is really severe, a splenectomy is done to remove the patient's spleen surgically to prevent it from causing any further hemolysis. Okay, that's it and that's all. If you want to learn more about this topic, you can check out some of the other videos that I've linked here. And if you guys enjoyed this video, don't forget to like or drop a comment and let me know. Also, don't forget to share this with others and subscribe to the channel so that you don't miss out on upcoming content. But for now, thanks for watching and I'll see you next time.